Good morning, everybody. Thanks for the kind invitation and the opportunity. Over time, we are attending an evolution of surgical techniques for rotator cuff repair from open procedure to more recent arthroscopic techniques. In 2006, it was proposed a new techniques for rotator cuff repair, the transosseous repair by arthroscopy. Actually, arthroscopic transosseous repair is not a completely new technique. We can consider it like a modern vintage fashion. In surgery, like in fashion, we often see the recovery of the good things of the past reproposed in a new look. The transosseous repair wants to combine the advantages of the biomechanical advantages of open transosseous repair and the clinical advantages of the arthroscopical techniques. And they want also exceed the limits of both techniques. We want to exceed the invasiveness of the open transosseous repair, but we also want to exceed the limits of arthroscopic techniques using suture anchors, like difficulties in the event of reoperation, the risk of anchor pull-out or anchor impingement in abduction, the bone osteolysis of the greater tuberosity, and lastly, the high cost of the suture anchors. From a biomechanical point of view, transosseous repair give a high failure load exceeding 450 newtons. It's true the transosseous equivalent gives a slightly higher failure load, but we see that in transosseous equivalent, the failures usually occurs in medial anchors, making the reoperation much more difficult than in transosseous repair, where the failure usually occurs laterally. From a clinical point of view, transosseous repair gives very good clinical results, also in long-term follow-up. We have a revision rate lower than 10% at 15 years of follow-up. Recently, several authors tried to compare the transosseous repair with other arthroscopic techniques. 2 years ago, we published a randomized trial on 69 patients. We compared the arthroscopic transosseous repair with single-row technique. We didn't find clinical differences in terms of clinical results and repair rate between the two techniques, but we found a faster pain reduction with transosseous technique. More recently, other authors compare transosseous repair and single row, and they didn't find differences in clinical outcomes and repair rate, but they found lower Sugaya type 3 healing in a transosseous group, and so we can think that the transosseous repair is better. No clinical differences were not even found between transosseous repair and transosseous equivalent. And moreover, in this study, we can see that the use of transosseous repair saved an average of more than $300 compared to transosseous equivalent, with no differences in terms of surgical time. Of course, also these procedures show some limits. First of all, we have a longer surgery time compared to a single row technique. It was a quite difficult technique with a longer learning curve for surgeons. And lastly, we had the risk of tunnel failure, in particular in all patients with osteoporosis. For this reason, we suggest to use this technique in a younger patient, in patients younger than 65 years old. We can perform an arthroscopic transosseous repair in different ways. We can use different tunneler techniques and different suture configurations. We can perform a bone tunnel using key wires. It was described, this technique, using 3 key wires with perforated tips. The key wires is passed through the inferior margin of the greater tuberosity and through the cuff, and then the suture are passed through the perforated tips of the key wires. It was a quite difficult technique, but of course it's really cheap. We can also use a cannulated needle to perform the bone tunnel. You have to pass the cannulated needle through the cuff 1 centimeter medial to the lateral edge, and then through the tuberosity. And then the wire loaded with a not absorbable suture is pulled through the needle. In the majority of the cases, we use disposable or sometimes also reusable devices to perform bone tunnels. The disposable device is, of course, more expensive, but they are popular because they make the procedure much easier. When we load the suture in the bone tunnel, we can repair the cuff in different ways. We can use simple stitches, in particular when we have a small lesion. But in the majority of the cases, we try to use an X-box configuration. In an X-box configuration, you have to do 2 bone tunnels, and you load 3 sutures in each tunnel. And you repair the cuff with 4 simple stitches, and then you cross and knot together the first and the last suture. With an X-box configuration, you can increase the contact area between the tendon and the bone, and the X-box configuration gives very good stability and good strength comparable to a transosseous equivalent suture bridge repair. When you have a quite big lesion, you can also use a triple X-box. You have to do 3 bone tunnels. You load 2 sutures in each tunnel, and you cross the suture together. In this case, the technique is a little bit more difficult, but it provides very good strength. Tomorrow, I will show you how we do a transosseous repair, and I also show you some tricks in order to make the procedure easier. Thank you.